Forgive me for the pretentious title, but as I'm going to explain in a minute, I mean, as you've heard from Sally, one of my particular research interests is cardiac rehab, cardiac rehabilitation, so I thought I might use this opportunity to be in Stirling today to talk about this topic, and I'll explain a little bit about why this thing with the Emperor's New Clothes and the capitals, NICE intervention. So basically what I'm going to try and do so the background of the talk is effectively there are sorts of two kind of key documents out there that inform this title. So one document is this report. So this is the report from the National Institute for Health and Social Excellence, as it's now known, but NICE, where they have a clinical guideline for secondary prevention in people who have had a heart attack post-MI. And their statement in this document was published 2007, and cardiac rehab at that time was the following: so that all patients, regardless of their age, post-MI, should be given advice and offered cardiac rehabilitation with an exercise component. So in other words, quite a positive, unconditional, if you like, support for the benefit of cardiac rehabilitation based on their review of the evidence that we'll talk about in a bit more detail. The other part of my title, though, really comes from this editorial, which was much more questioning. So this is an editorial from Robert West and Dee Jones, and the two of them had recently, the year before this editorial, published a large trial called the RAMIT trial. Interesting title in its own sense, but I'll come back to the RAMIT trial about what the RAMIT trial did and what it found. But basically the thesis is that here's two documents talking about the exact same evidence, but with very different conclusions. NICE being very positive, but as you probably see from this title, this editorial being very much questioning around, do we have enough evidence to be able to recommend exercise-based rehab for post-MI patients, particularly in the sense of will it improve their survival? So what I'd like to do is really use these two documents as a kind of platform for at least the initial part of my presentation today, because I think reading around the department's interests, the school's interests, there's obviously a lot of interest, I think, in complex interventions, as Sally mentioned. So what I'd like to do is really basically take this case study and share with you some of the challenges that I've had working in this area for about 2 decades and trying to build an evidence base around cardiac rehab, but really use that just as an example of, I think, some of the more common problems we've got when we're doing this for other complex interventions. So that's going to be where I start. And then I'm going to fast forward into, I guess, what's really my main current area of research interest, at least in the area of cardiac rehab research, which is really in the area of heart failure. Talk to you a little bit about what's going on in terms of the provision of heart failure in UK at the moment. Some of you may know this, given your professional practice. Talk about another Cochrane review that we've recently updated. And then last but not least, talk about my kind of main program grant that I have running at the moment called REACH-HF, and what that program is trying to do in terms of the generation of future evidence. So that's the two plans, if you like, a tale of two cities, a little bit around this complex interventions, and then we'll move on and talk about heart failure. Now, as Sally mentioned, I am a statistician and a trialist, albeit a physiologist, so do forgive me, but I'm going to throw a few numbers up today. Hopefully you'll not end up with these symptoms at the end of the presentation, but anyway, we'll wait and see how it goes. So let's start off then by talking about exercise-based rehab. Now, this was one of the first published, if not the first published, systematic review and meta-analysis of randomized controlled trials for exercise-based rehab in myocardial infarction, published back in Circulation in '89. And here's the key forest plot from that publication. I don't think there's a pointer, is there? So I'll use my digit, if that's okay. So basically, what this forest plot is looking at, first of all, is all-cause survival. These are trials where we randomize people to either get exercise or not. If the two treatments were equally effective, we'd have an odd ratio of 1, so there was no difference between the treatments. Everything would lie on the centre line. Anything to the left, a reduction in odds ratio, is a benefit of exercise-based rehab here. So the first thing hopefully you're going to grab is, if you look at the pooled estimate at the bottom, this review demonstrated that there's about a 20% relative reduction in all-cause mortality in those who take on exercise rehab versus those with control. What's also interesting is that when they came to do this review, I think there was somewhere in the region of about 20 trials contributed to this meta-analysis, and about 2,000 patients, so not a huge body of evidence by any means. But one of the first challenges they had is, well, what do we actually mean by exercise-based rehab? And some of the trials were very much trials of randomizing people to get exercise alone. But as you can also see, they had a group of trials, and in fact, this was a multi-center WHO trial in particular, where they had exercise plus. So in other words, not only did they get exercise, but they got other interventional aspects too. So positive evidence, but one of the things that this review very quickly recognizes is that exercise-based rehab isn't just about exercise, it can also be about other things too. And to reflect that, here's a very contemporary definition of cardiac rehabilitation. And as I let you kind of read through that, I mean, certainly it's not just about exercise, so-called physical conditions and improving physical conditions, but it's about many other things. And I guess the thesis I'm going to put to you this afternoon is that cardiac rehab certainly has many of the characteristics of what I would call a complex intervention. It's not just exercise, it's about psychological interventions, it's about education. People who deliver cardiac rehab are not just drillies like physiologists in a former life like me, physios, but they're also nurses in terms of promoting information around the use of medication. Also, we'll have psychologists involved in terms of providing mental health interventions. So again, multidisciplinary team delivery. Another area of complexity is that clearly what cardiac rehab is about, if you believe this definition, is trying to change a variety of different behaviours in individuals that may link together. So I'm going to put it to you that I think cardiac rehab for me is a very neat way of exemplarising some of the aspects, I think, of complex interventions. So kind of bringing it, fast forwarding from the very first Cochrane, the very first meta-analysis, there have been now 3 Cochrane reviews. This is the most recent one that we've updated. I think we updated this in 2011. And basically this review now consists of a total of 33 randomized control trials and about 20,000 patients. So a lot of evidence has now come in over the last decade or so around this particular question. However, when we look at that evidence, and here's a kind of forest plot where I've summarized out the main clinical events, what do we find from that evidence? Are we seeing much the same picture we saw before? Well, interestingly, when we look at all-cause mortality, again, this is on a relative risk scale, but effectively the same as odds ratios. You can see that there is a reduction in all-cause survival, although the upper confidence interval is now getting very close to 1, but certainly the point estimate is still about a 20% relative risk reduction. Most of that improvement in survival, not surprisingly, comes from cardiac mortality. That's the main reason that these people are dying less. Interestingly, though, if you look at non-fatal events, whilst there's evidence, again, of benefit, in this case, the 95% confidence intervals cross 1. In other words, we don't have formal statistical evidence that these are significant reductions, if you like. So looks as though at least the up-to-date evidence seems to continue to support the earlier meta-analysis, although we now have a bigger body of evidence. But the challenge, I think, with this body of evidence is now the tremendous heterogeneity that we've got within this evidence. And the next couple of slides try to capture that. So here's a summary of the trials that contribute to the meta-analysis. The first kind of observation is that how many of those trials are just about exercise? We'll answer only 19 out of the total, only about 40% of them. So we've still got this complexity in terms of other interventions here. Look at the range of publication dates. Some of these trials are now over 3 decades old. Variety of different locations. Not surprisingly, real mix of genders. Some of these are, believe it or not, men-only trials, some of the earlier trials. Again, wide range of age, mean 55, but going 48 to 71. And actually, most of these trials, although in post-MI populations, also include those with revascularization. And that could be coronary artery bypass graft, it could be a percutaneous angioplasty with or without a stent. So I guess just a long way of saying huge amounts of heterogeneity in that evidence base as well. If you look at the intervention and just the exercise bit of it, how consistent is that? Well, again, these are summaries over the trials, so although on average these exercise programs are 13 weeks long, look at the variation, anything from a month through to programs that are 12 months long. And again, you run your eye down, huge variations in terms of the dose of exercise being applied at the trial level within these various studies. So again, a sort of classic example when we do systematic reviews and complex interventions. We've got a complex intervention in terms of multi-component and how it's delivered, but also huge amounts of heterogeneity, therefore, in the evidence that we then identify typically and then have to try and synthesize. So how might we deal with some of those challenges? Well, clearly, as a statistician, one of the ways I'll try and handle that is to sort of say, well, can we stratify that evidence? Can we try and separate it out? So I guess the first question you might have is that does it make any difference whether I give an exercise prescription to a patient only, or also give them an exercise prescription, but also things like psychological management and education, so-called comprehensive rehabilitation, exercise plus. And basically, as you can see here, one of the problems we've got with doing these stratified analyses is that we've got more events from the trials from the exercise only, so the confidence interval is more precise. But the important point to note is that whether you get exercise only or comprehensive, both confidence intervals overlap, they strongly overlap, so do we have any evidence that one is better than the other? Of course, the answer is no. So it looks as though much the same. Does it matter how much exercise we give somebody? So we had a very simple way of trying to derive that, a so-called dose metric. You might say, well, what does this mean? A unit of 1,000 units here, if I remember correctly, is a typical prescription of about 20 minutes per week, 20 minutes per session, 3 times a week for a 12-week duration. That would be about 30 units. Does it matter whether people do more or less? Well, actually, again, one of the problems we've got is there are very few trials that have more than 1,000 units, so hence very imprecise, but again, huge level of overlap. And if anything, you might expect the mortality benefit to be greater here than here. Obviously, we can't rule that out. It could be this good, very imprecise, but certainly no evidence that there seems to be a difference in the type of cardiac rehab that we might deliver. Another way to kind of try and handle that is we've done Cochrane reviews looking at the other components of rehabilitation. So I mentioned to you that comprehensive is also about education and it's also about psychological interventions. So these are 2 reviews, one done by James Brown, one of our cardiac fellows, and Ben Wally, another fellow, where we basically looked at specifically cardiac rehabilitation interventions with a primary intention that was educational and a primary intention that were psychological. So in other words, they could include other components, but their primary intent was as stated here. And again, we've looked at all-cause mortality. And again, what you can see is that in this case, again, there seems to be evidence of benefit. So it looks as though these components have got effects independent of any other aspect, such as exercise. But of course, very difficult to do, because if you think about it, again, a complex intervention, how do you tell a trial where the primary intention was educational versus a trial where the primary intention was exercise? Well, you might be able to pull that out of the description of the intervention, but for those of you who know, when we read trials, typically the amount of information on the intervention in the text, how sure can we be about that differentiation? And I'd put it to you, it's very artificial. Another question we may say is that does it matter who received cardiac rehabilitation? Another level of heterogeneity. So again, here's this approach where we've stratified out the evidence, and I'll just cut to the chase. I mean, it doesn't matter how you slice and dice the data. It seems to be that there is no significant difference between those groups. So there's no particular reason to separate them out. While we were doing this review, one of the big policy issues was around not only what is the intervention, who receives it, but the setting in which it might be conducted. And some of you may be aware of this thing called the Heart Manual. The Heart Manual was developed in Edinburgh by a psychologist, Bob Lewin, and his team. And certainly from an English perspective, many primary care trusts, as they were then, were implementing their rehabilitation effectively using a self-directed heart manual. So in other words, this is something we can give patients. They don't need to come into the hospital, and they could have a nurse facilitator contacting the patient 2 to 3 times over the phone and just checking that they're progressing. And obviously for policymakers, that's very attractive because you don't have to drag them into the hospital, so that might suit patients more. But also, clearly, it may have a potential cost saving. We don't have to necessarily employ these people within a hospital setting. So what information do we have on this? Well, what we decided to do at that time was to do a randomized control trial, and this is going back now to the southwest. So this is a trial, the CHARMS trial, that we undertook actually in Truro, where we randomized people to basically get exercise rehabilitation, but get it in 2 different ways. So one, you could either have hospital-based rehabilitation, if you like, the traditional model, and most of the trials I showed you earlier were hospital-based, or you could have your cardiac rehab delivered to you by the Heart Manual, and you could be randomized to home-based. You may notice that what's interesting in this trial design is that we also put what's called a patient preference arm. This is a comprehensive cohort design. When we were preparing this trial, one of the things that we found out was that to consent to be randomized, patients had to have no preference. I'd be happy to have my rehab rod, but it doesn't matter whether I have it in the hospital or home. But actually, do patients have a strong preference? Well, actually, a significant number of them do. So when we consented them to this trial, you can see that of the 230, 126 of them had a very strong preference, so we couldn't randomize them. So in other words, we had to give them what they asked for, and indeed we decided to follow them observationally. But cutting to the chase, although very small numbers, okay, health warning around the stats here, doesn't matter whether they're in the randomized arm or the observational arm, both groups appeared to benefit equivalently. And indeed, what we were able to do was to then bring this trial together with other trials and bring them together in this meta-analysis. So there were another 10 randomized control trials looking at this head-to-head comparison. Here's just an example of the mortality outcome. So again, these are the various trials. The trial I just mentioned to you, the CHARMS trial, is the DELAL trial. But is there any difference in terms of the mortality benefit one gets, whether one does this in a home-based setting or a hospital setting? Well, again, we've got to be cautious. The number of events here is very small, a total of 31 events out of 1,000 patients-ish. But doesn't appear to be any evidence of the difference. And of course, we were able to look at a whole raft of other outcomes. If you're in the cheap seats at the back, you may be struggling a bit, but basically just to suffice that there's no difference in terms of any of the outcomes we looked at: exercise capacity, blood pressure, cholesterol, high density lipoprotein, smoking, or indeed mortality, as we've just seen. So does the setting for cardiac rehab matter? Doesn't seem to. But again, it's another aspect in terms of that complexity. Now, as I said to you, one of the things about pairs, and pairs are often led by pounds, aren't they, is, well, what was home actually cheaper? And you might think it was, because to actually buy the heart manual is about £20 a pop per patient. So you might sort of go into this thinking, well, a kind of key driver here is that, well, if the manual's just as good, it's cheaper, that would be the option you'd want to go for. So we wanted to look at the health economics around this issue too. But remember that Heart Manual isn't just about giving them the manual. It needs some degree of individualized telephone follow-up. So this basically, what we wanted to do was to say, well, is there actually any difference between costs and outcomes? And actually, interestingly, the answer is no. So when you look at the total costs, and these are per patient, if anything, home's slightly more expensive, so about £3,279 per patient, whereas that cost for the hospital-based patient was only £3,200. No significant difference between the two. Obviously, again, we've got to be very cautious. The numbers are small, and again, we collected quality adjusted life years here, and not surprisingly, given the other outcomes were the same, we didn't find any difference. So our conclusion was here, although we didn't formally design this as an equivalence trial, we've got no evidence to believe that there is indeed a cost difference between these two settings either. So I think this notion for PCTs that, you know, home-based rehab is just a cheap option, well, actually it's not. But importantly, it's no more expensive, but also it's as effective as what we do in a hospital setting. Qualitative research is certainly not my area of expertise, but I'm fortunate enough to have in our research team individuals where it is. So Jenny Wingham's one of our researchers, very strong in this area. So while we were doing this research, one of the things we did was Jenny ran a study asking patients about what did they think about the setting in cardiac rehab. And a little bit like the comprehensive cohort design we saw earlier, is that for patients, setting is very, very, very important. So, you know, if a guy like myself, age 55, very high point in my life for having a post-MI event, if I was going to have my rehab, would I want to go into a hospital setting? Probably not. Given my type A personality, I'd like to get straight back to work. So having my heart manual so I can be cycling under my desk, yeah, I know I'm a bit sad, would be a perfect option for me. So just a long way of saying that if we've got evidence of equivalent costs and benefits, I think there's an interesting dilemma for the health service here, that do we provide both options to patients and allow them to choose from preference? Certainly that was our recommendation in this research, and indeed in the Southwest, that's very much the model that we do run. Of course, that assumes that you can provide that infrastructure. So far so good. It appears that cardiac rehab works if you believe the evidence I've given you, and it works in terms of reductions in mortality. And those are largely driven through cardiac mortality, and it appears to be that those effects are broadly equivalent across different patients and in different settings, and whether one talks about exercise only or comprehensive. But let's go back to my title. And as I said to you, there is certainly a camp of individuals out there who are much less positive about cardiac rehabilitation than others. And here's Robert West again. So he was one of the authors, if you remember, of that original editorial I showed you. And this is the trial that I mentioned, the so-called RAMIT trial. Now, the RAMIT trial is very important for us because systematic reviews, of course, look at international literature. And while some of those trials come from UK, this was the largest randomized controlled trial of UK practice that had been commissioned. It's an interesting story we'll come back to. It was actually commissioned in the late 70s, early 80s, but took 20 years to be published from the point of commissioning, and we'll come back to that. But the whole reason that this trial has caused, let's say, some debate is this following Kaplan-Meier curve. So this is basically, again, a trial where we're randomizing units to either get rehab or not rehab, and this is comprehensive rehab with exercise. But if you look at all-cause mortality, you can see that over the 7 to 9 years, I mean, there's absolutely no difference between the green and the red, is there? Tiny bit of difference in the center there, but when you look at the pooled relative risk over the full duration of the Kaplan-Meier, 2,000 patients roughly randomized here, so this is a big buggery trial, but no difference in all-cause mortality. So you might be sitting there saying, well, what does that do, Rod, if you add this trial into the previous systematic review that you did? And here's the answer. So here's the RAMIT trial, so West, the first author. You can see it's absolutely plumb on one, but it's very, very tight, isn't it? Because this is giving us a lot of events. This is a big trial. Interestingly, when you put it in, what's the overall evidence? And actually, still a benefit, but notice what's now happened to the confidence interval. We're right on one at the upper end. So we've got evidence that appears to work, but actually the one big trial that we have from our UK practice looks to be negative. So what's going on? Well, as you might imagine, there's been a huge amount of debate around this particular trial, and this was the rebuttal by Robert Loon and Patrick Doherty, two from the rehab camp, where their view was, well, actually, the emperor is properly dressed here, Dr. West. And what's been interesting is that has been at least some of the discussion has been around the criticisms of the RAMIT trial, which I want to share with you because, again, I think it's some of the challenges of doing complex interventions in the real world. So first of all, this trial was powered for 8,000 patients. How many did it actually collect? Well, if you remember, it was about 2,000 patients entered this trial. And that's because it was just very difficult to do. And this trial, remember, was commissioned when we had already the meta-analysis published by O'Connor and ourselves that rehab worked. So you can imagine what services were thinking about trying to take part in this trial, trying to recruit centres to be randomised to something we have evidence that does work. That's really quite a tough ask. So I kind of feel for them, but where I don't feel for them, I'll just put my own biases out there, is that despite huge amounts of discussion in the literature, what we haven't been able to do is to get any information in the public domain, it's not in our original Hart paper, on the nature of the rehab that they delivered, the quality of it, nor what was the adherence to that rehabilitation in the trial. Because of course, they probably are going to be potentially quite important here. One of the hypotheses that the authors themselves had was that, well, perhaps the reason that rehab isn't working is that rehab is less effective in today's modern era of cardiovascular treatments. So let's have a think about that. So trials done back in the 70s, I mean, access to ACE, beta blockers, etc., much, much less. So is the benefit of rehab in the early trials largely down to the fact that basically it was just getting patients to adhere to their medical treatment rather than the exercise per se. It's a hypothesis, isn't it? So what we decided to do, and in fact this is a plot that we had in a letter in response to the RAMIT trial, is to ask the question, and forgive the maths here, but basically this is the log of the hazard ratio. Each one of these blobs is a trial, so we updated our meta-analysis with the RAMIT trial. That's the RAMIT trial there, big blob, a lot of patients. And we asked the question of, is there any evidence that the relative risk changes over time? And you may say, a few pints of lager on a Saturday night, that's pretty much a straight line. And indeed, the slope is quite shallow, 0.08, not significant. But the point is that it is actually a slope. And actually, if you exponentiate that, it's about a reduction in the benefit of rehab of about 8% for every 10 years of publication. And if you think that rehab's been around now for about 3 decades, we could be losing 20% relative risk reduction with this effect. So is it possible that we're not getting a mortality benefit? Well, our kind of conclusion was, well, we certainly can't rule that out. So again, an interesting point of complexity, the same intervention, but over time maybe having different effects because of the context of care. Another issue, of course, that may be going on with the RAMIT trial is that was the practice in the RAMIT trial much more kind of real-worldy than what were in the other trials? And this was just an analysis that myself and Hugh Bethel did, where we compared the previous Cochrane review versus a survey done by the British Association of Cardiac Rehab of actual practice. So this was the population characteristics in the trial. This is the intervention, and then cast your eye to what was actually happening in reality. So things to note: patients who are treated in reality much more likely to be older, much more likely to contain women, and importantly, much more likely not to be dosing themselves at the same level of intensity than in the trial. Now, unfortunately, we can't get the information from the West trial. We're still trying, but I mean, one plausibility is that basically the intervention was underdosed, or if it was prescribed, patients did not adhere to it. And of course, if you don't take the treatment, it doesn't work. And I guess just to kind of perhaps put a health warning around some of my kind of analysis, clearly my analysis perspective is a quantitative one. But for those of you who are out there who are more qualitative, this is obviously a lot about complex behaviours too. So just to say, there is a huge body of evidence. For instance, this is a meta-review of qualitative evidence looking at women in particular's perceptions around how they might want to adhere to cardiac rehab. So just because we're giving them something doesn't mean to say they're going to take it up. And again, here's just another analysis from a collaborator of mine, Alex Clark, out in Canada, where he's done something similarly, showing that the sorts of behaviours to get people to actually attend and then comply with cardiac rehab is very complex. So this is not a drug, here's the drug, take it, Rod, and then you'll get your treatment benefits. This is very much about a contract that one has at an individual level within a person to make those changes. And I guess the last point I want to make to myself really is that you may be sitting there saying, well, Rod, all you've talked about so far are events and mortality. But of course, if you ask patients, why do you want to do rehabilitation? Well, quite clearly, if I do have my MI, hopefully not this weekend, part of my reason for doing rehab might be to lengthen my life, but actually my main rationale will be to improve the quality of that life. So in other words, what's the appropriate outcome for this complex intervention? And I'd put it to you, and indeed we've got very good qualitative evidence, that it's not just about mortality. It is very much, in this case, about health-related quality of life. And indeed, we've now implemented in all of our systematic reviews around cardiac rehab the collection of quality of life data. But again, just the point to make to all of you involved in systematic reviews is that it's a bugger to deal with analytically, isn't it? I mean, everybody uses different quality of life measures. So in this case, this is just one trial that used the Nottingham Healthcare Profile, which is a generic measure, but we've got disease-specific measures. We've got other generic measures, SF36, Euroqual. How does one synthesize that data? Well, the answer is you can't quantitatively. You can do very kind of naive things like vote counting. So in this case, you know, how many trials, how many outcomes was exercise more beneficial to usual care? But there's huge amounts of problems with doing that sort of analysis. I might come back to that. So, long way of saying, I think clearly we've got a lot of evidence that cardiac rehab's complex intervention, and as hopefully as I've shown you, that 20 to 30 years where I've been involved in around that evidence evolution and the RAMET trials, some very interesting issues about trying to tease out some of those issues about does the treatment work and in which people and which settings might it work. So I'm going to move on now to talk a little bit about heart failure. And I guess this is much more the area that I'm actively working in at the moment, because the agenda for essentially post-MI cardiovascular rehab has moved on. NICE have recommended it, and certainly, at least in down south, it's been pretty well implemented now, despite the RAMET trial. I think I've got some timing on my slides, so they go back every so often, so forgive me for that. The question is, how about heart failure rehab? So what we decided to do a wee while ago was to do a quick survey and have a wee look at what's going on. So this is a busy slide. What we were able to do through the BACR, the British Association of Cardiac Rehab Register, unfortunately Scotland don't subscribe to that register, don't shoot me for it, but basically 277 centres and everywhere south of Hadrian's Wall and also Northern Ireland. We sent them a questionnaire and basically asked them questions around their provision of rehab. So these are rehab centres, and we wanted to know, do you provide rehab for heart failure patients? 90 of them said yes, but interestingly, a number of those programs were including patients with heart failure, but not bespoke programs for those patients. They were just including them where they came along. And if you think about it, the main reason for having heart failure is having a heart attack. And if you've already got a contract with your PCT for a heart attack, if they've had a heart attack and they've gone on to have heart failure, you can have them when they've got their heart failure too. So about a third of programs-ish had services for rehab patients for heart failure. But interestingly, only 35 out of the 224 returned had a specific rehab program. So in other words, clearly there seems to be an implementation issue here. And if you ask them the questions about, you know, what are some of the barriers to providing heart failure, it's the kind of things you'd expect. Resources, I read resources always as money. So, you know, who's going to be funding the service? And indeed, if you link that, you know, many of these services said that they didn't have a contract with the commissioners to do so. But interestingly, very few of them identified the reason that they weren't providing rehab for heart failure was because that they didn't believe it, there was no evidence. So what is the evidence? Well, again, I think this is the first outing of this update. So this is our latest update for heart failure. So at the bottom, 33 randomized control trials, 48 publications. So these are the same designs, but specifically now looking at rehab for people with heart failure. And here's the results. So now about 4,000 patients randomized, so about half of the total we had for post-MI revasc, but still a significant proportion. Most of these people are heart failure with left ventricular systolic dysfunction. We'll come back to that. Interestingly, again, we've got the same issue with mortality, I think. Seems to be a mortality benefit, but it's quite small. I mean, I'm not going to argue that there is a mortality benefit here. Some evidence in longer follow-up. But what we've got very good evidence for in heart failure is reduction in downstream hospitalisation. So these people are much less likely to be readmitted to hospital, particularly for heart failure reasons. And also, one of the neat things in this area is, unlike other areas, people kind of measure quality of life using the same metric. So this is the Minnesota Living with Heart Failure disease-specific measure. 13 of these trials collected it. A reduction here is a good thing, and a clinically meaningful difference is about 4. So we've got a significant reduction in the Minnesota that also appears to be clinically important. Now, these trials don't include another type of heart failure, or people who have don't have left ventricular systolic dysfunction. They've got a normal ejection fraction. So we did a quick systematic review, very little evidence in this area. Be warned about this slide. Again, this is the Minnesota. I think 2 of these studies are non-randomized and the other 2 are randomized, and they're very small. But again, what's interesting is that although this body of evidence is small, we're getting very equivalent, it looks like, effects in this other type of heart failure too. And what's interesting is that these patients are typically excluded from trials. People with HFpEF tend to be women, they tend to be multi-morbidity, and they tend to be older. But are they in need of treatment? Well, of course they are. So what does NICE say about this? So this is NICE's commission through the Royal College of Physicians guideline on chronic heart failure. And I'm pleased to say they did read our evidence, and this is their recommendation, that rehab should be provided. But interestingly, most of these trials, if not all of them, are based in hospital settings. Because remember, heart failure, a bit more risky. So these people really can die. And indeed, one of the reasons for doing trials initially of exercise was to ask the question of, were they more likely to die than not with their exercise? But that's fortunately not the case. But offer rehab, supervised in a group. Again, these patients need to be stable. This notion that rehab isn't just about exercise, but it should be psychological. But interestingly, they also noted, because of our survey, that you should really not just implement it in bespoke rehab programs for heart failure, but it can actually, you can integrate these patients with post-MI. Why not? So I guess that now takes you to the point where my research interests come in, because one of the things that we don't have in this area is the equivalent of the heart manual. So that manual that we saw earlier for post-MI and revasc has only been, if you like, designed for those populations. But as I think I've hopefully shown you, patients do have a strong preference around their type of rehab. And at the moment, we really don't I think we've got good reason to believe that patients might want access to either. Lack of evidence on what might be an effective and cost-effective home-based intervention. We've also got a paucity of qualitative evidence in this area. And then finally, we've got this subgroup of patients with preserved ejection fraction where we really don't have a lot of information. And armed with those, if you like, 4 bullet points, we popped in a proposal to NIHR, which I'm very pleased to say was successful, and led to this program grant, which I'll talk to you about for the next couple of seconds. So this is the REACH-HF program. And basically, we said we'd try and address each of those problems. So first of all, we would develop a theory-based home self-help rehab manual, heart failure manual for people with heart failure, but also their caregivers. So we've done some qualitative work showing, not surprisingly, that if you want to change behavior of people like me, you don't talk to me, you talk to Mrs. Taylor. Clearly, it's a complex intervention. We needed to pilot it first. And indeed, we wanted to look at a pilot in the HFpEF group, full trial in people with, if you like, left ventricular systolic dysfunction, forgive the different terminology, and their caregivers. And then, because at the end of the day, all of this work has to generate policy change, you've got to do some modelling at the end. Are these interventions cost effective when rolled out? So we're 1 year in. This is the program. I won't go through it, but basically this is the people who do the work. I just kind of come and talk about it. We've got 4 centres involved in this study, so York, Birmingham, Abergavenny and Cornwall. Cornwall Exeter's kind of my bit. Why these 4 centres? Well, interestingly, those again of you who do trials will know that recruitment is always the problem. We've got very good relationships with each of these, so the PIs in each of these areas have done trials in this area before. We all know each other, and basically we can hopefully rely on the fact that we can recruit into these centres. In Exeter, we're kind of leading, I guess, the project overall, myself and a research GP, Hayes Dalal, are the CIs on this study, but very much recognising that in our first year, which is just finished, so this we're now into 14th month of funding, has been about developing a theory-based intervention which has been led by Colin Grieve, a health psychologist, together with Charles Abraham. Some of you may have heard of him, but basically really bright people trying to work out how do you build interventions from the bottom up. It's not just this is the bits you think work, but what is the theoretical basis of that? I mean, again, I'm not a qualitative researcher, but these people tend to talk on things like models. You've got to have a model, Rod. You can't develop an intervention. So this is our model. I'm sure you understand that better than I do. And I'm delighted to say that after about 12 months of funding, we now have our 2 manuals. And here they are. So we've got a manual for the patients, and we've got a manual for the caregivers. These are the contents pages. So the manual for carers, about 36 pages long, 175 for the patients. That seems a bit long to me. Yeah, exactly my reaction. Interestingly, the heart manual for post-MI is 150. So, yeah, but remember, these are not manuals that you read through from start to finish. They're kind of resource manuals, and you complete bits as you go along. Anyway, we're just about now to start to trial these. So we're just entering into our feasibility stage. So we've built the interventions, if you like. What we're now going to do is evaluate them. So very exciting. And maybe 18 months, 2 years' time, you'll invite me back and I'll tell you how it goes. So some concluding thoughts, maybe. I'm conscious of time. So certainly, I think, hopefully, I've convinced you that exercise-based cardiac rehab is certainly many of the features of a complex intervention. And for that reason, I think it's been a challenging one to manage its evidence base over the last couple of decades. This is kind of like teaching my granny to suck eggs, so I'm kind of putting this up here with a high degree of hesitance because you know all this. But I think the important point is that when we're looking at systematic reviews or indeed designing trials for complex interventions, it's really important that we take into account that complexity. And of course, we've got the great and the good who have written the MRC framework for complex interventions, which I'm sure you're all very familiar. But I think from my own personal perspective, one of the big problems we still have, particularly with trials, is just this issue. When I go to publish a trial, not only do I need to tell people about the detail of how I did the trial, but it's really important about the details of how the intervention was designed and how it was delivered. And again, I know you know all that, but things like, how were the staff trained, what was the fidelity of delivery and patient level compliance. Now, fortunately, we're getting into a day and age where we can provide a lot of that stuff on out there on the extra bits that you can click on when you're reading publications, but it's still a pressure, and many journals still don't let you have that space. Systematic reviews, in other words, trying to make sense of all of this. I really like this quote from Pettigrew. We've got to think beyond the PICO, the population intervention comparison outcome. It is thinking about, what's the theoretical basis when we're doing a systematic review? Are there any causal pathways? Exploration of heterogeneity. Hopefully I've shown you at least examples of that, how you can slice and dice the data differently. And also I think, bringing qualitative evidence into play when one's reviewing the quantitative evidence as well. Absolutely critical. And also, are we critically appraising our literature the same way when we do complex interventions? I don't know the answer to that, but I'm kind of don't think it's just the classic RCT checklist kind of works here. It's a bit deeper than that. So, really last couple of slides. So this is, I guess, just to give you a flavour for some other things that I'm up to at the moment, or our group are up to. So again, I think one of the opportunities for complex interventions is to do what are called individual participant data meta-analyses. I'm sure you've come across these, but not only do you get the data at the aggregate level, but you get all of the individual patient data from all of the trials. So we're trying that. It's my first one, and it's a bit of a baptism by fire, actually, trying to get the data off investigators, but so far so good. So this is ExtraMatch 2. So myself and a whole cast of much brighter people from various parts of the world are basically going back to all of the investigators on that update Cochrane review and asking them, can we have the individual data? Because then we can really get into the issues about, and again, this is far too long a list, but asking questions about, what patient characteristics do impact on outcome. And also, go in and say, well, does the nature of the intervention impact? And you can only do that with IPD. One can't do this at an aggregate level. Anyway, we're up for it. What happens, we'll wait to see. I think another reason for doing kind of systematic reviews is that they can actually identify evidence gaps. So this is just one that came out from our Cochrane review done by Ben Wally. So we said that it's really important that when people get cardiac rehab, that some patients, particularly those with new onset depression, may need a kind of boost of psychological intervention over and above their usual rehab. And actually HTA bought that. They put out the scope, the research question, and I'm delighted to say that we've managed to blag that trial. Again, this is far too detailed a consort trial, but we've just got this trial in Exeter and across a variety of locations in the southwest. So we're going to try and see if we can address this question. So in other words, using systematic reviews to identify evidence gaps and then going to get the money to do the trials, close the gap, and then that virtuous circle is quite a good thing to do. And then last but not least, what we're doing at the moment is just doing, some of you may have come across this is very anorak now, where you do reviews of reviews. So an overview of a current Cochrane portfolio, what are the opportunities for lumping and splitting? What are the gaps in the current evidence base? And really what's been interesting is that we've got a group of stakeholders involved in this telling us what we think the reviews from their perspective should look like. That's a bit scary. But anyway, we're trying that out because at the end of the day, I mean, these reviews are read by policymakers, and if they don't like them, well, what's the point? If you want to know more, we've got a wee bit on our website. So this is our Cochrane Rehab review page from PENTAG, so the Peninsula Technology Assessment Group. And if any of you are interested in REACH-HF, again, this is off Cornwall Trust. They're the sponsors for the trial, so they've got our website. But you'll be glad to know that's it. Thanks very much for your attention.
Mary Wells. I really, really enjoyed that. Given that you mentioned the issues of timing and preference, and you kind of alluded to the issue around clinician preference as well, which I think is particularly interesting, or at least clinician beliefs about an intervention. Are you anticipating that you're going to have any of those problems with the REACH trial? Because it sounds like you've got a kind of committed group of people who are interested in heart failure rehabilitation, and I think that's a real issue that, by the time you get funding, you get R&D permission, you get all these things up and running, you're usually working with a group of people who've got fairly keen views one way or the other. Yeah. And I just wondered whether that had been an issue and what you were doing about it.
Yeah. No, very perceptive question. I mean, the long and the short is that we've had huge problems trying to get this trial off the ground locally. I mean, I don't know how it is in Scotland at the moment, but trying to negotiate excess treatment costs. In other words, getting the so you get your research grant and you think, that's it, I can now just get on with the work. Of course, that's the beginning of your troubles. What you've got to do in England is you've then got to agree with the NHS that they're going to provide the intervention and pick up the costs, and it's called excess treatment costs. So we've had huge problems doing that. And in fact, basically it's taken me 6 months as of yesterday for these 4 centres where we've got very committed individuals, key opinion cardiologists who believe it and can present that case to their CCGs, have we been able to get the excess treatment costs agreed? So I mean, the short answer to your question is distinctly yes. Where I guess I have a bit more hope is that I think one of my general worries when I'm doing trials is the whole issue around external validity, therefore generalizability. So you're right. So we have got very much enthusiasts in these 4 centres. So are our results going to be generalizable? I think they will be. Part of that is that, I mean, at the end of the day, certainly the social demographics of these different areas, particularly Birmingham. I mean, I was in Birmingham before I went to Exeter, and you know, we've got very much an Afro-Caribbean population there, and indeed we've had to translate some of our materials so that they can be delivered there. Again, I think part of the challenge of this trial is also in terms of patients. I do worry a little bit about this trial because a comparator is usual care, and usual care is effectively nothing. But you'll have said, well, look, Rod, you just showed me a whole array of evidence showing that if I get centre-based rehab, it's good for me. So am I going to be able to recruit to this trial from patients' perspective? Again, it kind of keeps me awake at night. The one thing I kind of go back to, though, is that we do know from our survey that actually the provision of rehab is still very poor on the ground. So for these patients, if we offer them entry to the trial, it may be their only opportunity to get at rehab. But you know, if there is a very good centre-based programme locally, we're going to be whistling in the wind, I think. So not a terribly positive answer, but I think what you say is absolutely right, is doing some of these trials in the real messy world is really quite difficult. And that balance between getting enthusiasts on board who can help you actually do the research versus then being able to generalise that model out when you've got your results is a real interesting tension.
I'm really pleased to see that you've designed a caregiver resource. And I wondered, in addition to the resource, what type of variables are you measuring with caregivers?
Yeah, no, great question. So again, we've had a huge discussion around the caregiver. So essentially let's be honest, my very naive premise was that, well, carers were important because it would help to improve the outcomes of the patient. But of course, as those more knowledgeable in our research group tell me, well, what about the outcomes of the caregivers per se? So as well as recruiting caregivers, we are actually going to track their outcomes. And this is where I'd want to normally say, Jenny, please tell me what the outcomes are. But I think it's things like the caregiver burden scale. We've got a HADS in there for them, so we know that many caregivers are anxious and depressed because of the role that they're in. I think we're also going to give them a generic quality of life measure. I think the SF-12. So in other words, we're going to track the outcomes of these caregivers. In other words, how do they react in terms of their specific part of the intervention, as well as as well as doing a parallel process evaluation, interviewing couples or partners and carers, because of course sometimes carers are not, they're not your wife or your husband, and asking about the importance of that interaction. So in other words, is there real added value for having a separate intervention for carers, or is it, is it really just kind of lip service we're giving to that? Is there something important there?
Thank you. I really enjoyed that, Rod. Can I just pick up on the 100 and however many page booklet, which
yeah.
I'm coming now from the perspective as a GP who worked in disadvantaged areas, where I can think of many patients who haven't got a book in the house. How can you be certain that your intervention won't increase health inequalities? And I suppose that I'm also thinking about some of the work that we've done looking at group interventions. And one of the things with group interventions is that they tend to attract your most confident, resource-rich individuals, and your more disadvantaged, depressed, anxious people will tend to perhaps go once and then drop out or not go at all. I wondered if you thought about that at all.
You can probably see from my reaction, not terribly, but I do sense it's readily important, so I probably ought to be asking you for some tips on this one, and we will do that over lunch, please, genuinely. I guess the one thing that we are doing is, in the feasibility part, is trying to look at that question directly. So at the moment, our recruitment criteria is consecutive patients. So these are patients who are either identified through general practice, through effectively prevalent heart failure cases, or incident heart failure cases that are identified in cardiology. And we are really trying to encourage consecutive patients to be offered entry to the trial. So I guess we'll be able to at least look at that issue of, from the point of offer to the point of acceptance, what is the delta, and how much of that inequality is going on there. But I do really worry about that. Clearly, in terms of the previous trial, I showed you the CHARMS trial, the heart manual trial, which we replicated in Birmingham. Actually, we found that to be less of an issue, because certainly for some groups, going to hospital was really limited their access. But of course, the comparator there was hospital, and we were offering them a home-based. So in other words, we were able to actually engage more people. But again, problem with the comparator here, we don't have an active comparator, so we may be doing the opposite inadvertently, as you say. So
I think the caregivers might be important, because certainly in terms of accessing groups, quite often if you can go with somebody, it makes a huge difference. It's that walking into a strange place where you don't know what's going to happen. Is, from the qualitative work we've done on groups, is just absolutely key. And we've just completed an HTA review of systematic review of obesity in men. And that's fascinating, because actually far fewer men engage in obesity management than women, but the men who do engage do far better.
Interesting.
And the FIT trial, which I suppose you know about them, the men-only interventions with the Football Premier League, was extraordinarily successful. So if you get and that's about getting the place right, which is referred to, and the meaning right, and then that makes all the difference.
Perhaps I could have one, or two even. I was fascinated by your individual analysis level of data, because I think in terms of looking at the interaction between personal characteristics and intervention type, that's potentially an opportunity really to explore some of these issues, what kinds of interventions work for what kinds of people. It kind of links back to the idea also of, whilst we have UK databases, what are they called? Repositories. I think it would make an extraordinary sense to actually have really detailed protocols and also descriptions of interventions actually in a repository, so that you can actually tie together your data and your intervention and the real life details of the design when things didn't necessarily go right, because it really is the big gap. We don't understand what's actually being delivered. And if we had that level of detail, probably presented in a systematic way, that would allow us to actually develop kinds of metrics around intervention design. So I would see that as being a potentially fruitful area for development. Is there any work going on in that area?
Well, I mean, just to echo, I think you're right. A bit like when we do a trial, we have to register the trial as a number and then, publish the protocol. Should we also have to publish or make available the intervention manual? I think that's a grand idea. Susan Mickey and Charles Abraham are having what I believe quite high-level discussions, certainly with NIHR, about trying to actually implement that, because it's not that difficult to implement for NIHR-funded trials. Now, I know that's not the world by any means, but at least that would be a start. So, in other words, if we as decide to put money into those trials, an expectation is the manuals are available in the public domain, not just at the end of the trial, but also up front. So you've got a kind of, it's a bit like that kind of pre-statedness, isn't it? That, people come up with their post hoc rationalizations, as I'm sure I will, but that evidence was out there at the beginnings, and it wouldn't be terribly difficult to do, you think?
And I think also you could get an agreement at a UK level, at least across research councils and NIHR, to actually have a standard format.
Yeah.
It's not rocket science, I don't think.
No, great idea.